Christian Doppler was born 1803 as the son of a stonemason in Salzburg. He not only lived in Salzburg, but also in Vienna, Prague, Slovakia, and he died in Venice, where you can still visit his tomb. His groundbreaking work was actually on stars, on the color of binary stars. Without the help of Christian Doppler, we would not perform echocardiography the way we perform echocardiography today. Christian Doppler obviously wasn't interested in quantifying the severity of aortic stenosis. He was interested in determining how fast stars travel. And he observed that if there is a change in the color of these stars, in other words, a frequency shift, then we can also calculate the velocity and the speed with which a star travels. The story goes that in 1845, Doppler tested some of his equations which related to his theory. And he placed a group of trumpeters on a railroad flat car and a group of musicians who supposedly had a perfect pitch near the tracks. A locomotive then pulled the flat car back and forth at different speeds for over 2 days, and the musicians recorded the apparent notes that they heard when the train passed by. This experiment then showed that his theory was correct. How does all this relate to echocardiography? Well, with the help of Doppler, we can measure the blood flow velocity and also the direction of blood flow. The principle behind is quite simple. The transducer emits an ultrasound wave with a certain frequency. And this ultrasound wave hits a blood cell which is moving. And because it moves, the reflected ultrasound wave has a slightly different frequency. And from the difference between the send and the receive frequency, we can calculate the velocity with which the blood cell travels. For all of you who are really into mathematics, here is the so-called Doppler formula. You can also find this formula in your fact sheets. I just would like to emphasize that the calculated velocity not only depends on the Doppler shift, but also on the sound propagation velocity, which we assume to be 1,550 meters per second in human tissue, the transmitting frequency, and most importantly, also the angle with which we interrogate the moving structure, in other words, the blood cells. So in Doppler echocardiography, the angle plays a very important role. And we should always try to be parallel to the jet or to the blood flow velocity. If we are parallel, then the measurement error is practically zero. But the more Doppler angle we have to the bloodstream, the bigger the velocity error we'll get. And if we are perpendicular to the blood flow, we can't even tell in which direction blood flow occurs. In echocardiography, we use two different types of Doppler: the pulsed wave Doppler and continuous wave Doppler. With the pulsed wave Doppler technique, the transducer always switches between send and receive. So pulses of ultrasound are emitted and reflected. And because we can correlate exactly the send with the receive signal, we know at what distance and also at what velocity these blood cells, for example, are traveling. So in principle, how does that work? Well, we have the ultrasound ray and we have a certain sample volume. As you will see later, we can adjust the sample volume, and then we will measure the blood flow velocity within this region. And here we can see the typical Doppler spectrum, in this case of mitral inflow. We have a timeline, and we have the velocity scale right here. So this is the typical spectral pattern or the spectral display of a pulsed wave Doppler. In this demonstration, Marion showed us how we can acquire a continuous wave Doppler spectrum in a patient, or actually an individual, with physiologic tricuspid regurgitation, something which is often very difficult to do, especially if the signal is very weak. But there are many, many other ways we can use continuous wave Doppler as well.
Now let's see a little bit the Doppler functionality of the systems. Let's first start with the PW Doppler. You see, I have my 2D image. I adjust already my cursor. I have a small line in between. This is basically where you place the sample volume in. You press on PW. Now we need to optimize the signal. The first thing, of course, like every time, adjust your gain settings so you have a proper signal here. Then you may change the baseline depending on what what you want to see, the inflow or the insufficiency. In this case, we only have the inflow, so I would remove the baseline a little bit lower. And then to get the really nice signal that fills the screen, you can change the scale, that you have an optimal position here. This, the same as in M mode, you can also change the horizontal sweep here. If you want to do some time measurements, it might be interesting to get a little bit faster sweep speed, so you can measure a little bit better the timings. Or you may decrease the sweep speed in order to see some changes during respiration. And when you freeze the image, you can again do some post-processing. And here you still can change the gain settings. You can move the baseline a little bit more up and down if you just realize that it's not perfectly. You can still change it a little bit. Or you can still change the horizontal sweep. So these three things can be done also in post-processing. If you have difficult to scan patients, you can just freeze it and do this afterwards.
The advantage of pulse-wave Doppler is that we can determine exactly where we want to measure the velocity, within the region of the sample volume. The disadvantage is that we can only measure velocities which are somewhere in the range between 1.5 to 2.0 meters per second. However, since normal flow velocities in the heart are not above 2 meters per second, at least usually not, we can measure most velocities with the help of pulse-wave Doppler. However, in settings, as for example in aortic stenosis, we will have a problem. In this case, we have to use another technique, continuous wave Doppler. But what do we do if we have velocities above 2 meters per second? Well, then we can use another technique, continuous wave Doppler. Continuous wave Doppler works differently. Here we have some elements which constantly send a signal and other elements which receive. And this is how such a spectral Doppler tracing looks. Note that we have velocities which are very high, 6 meters per second, and that we have a signal above the zero line and below the zero line. In other words, a signal which is directed towards the transducer and one which is directed away from the transducer. This is aortic regurgitation, this is aortic stenosis. But now it's Marion's turn to show us more.
Now let's follow up with the CW Doppler. In comparison to the PW, where you have a measurement gate, the CW measures all over along this line here. In some systems, like in this one here, you may have a focused CW, where you have again this small line, and you need to have this small region of interest in your area where you want to measure. Now let's see what we can adjust. CW. The same as in PW, you adjust the baseline, you need to adjust the scale, the gain settings. And what also sometimes might be very interesting is to have the sound of the Doppler, because this also gives you an indication if your cursor is positioned properly into the signal. So you have the loudness here. And now you get also the okay. One thing you should maybe also take into account, the system now, as you can see, is running with the 2D, the color flow, and the Doppler in addition. This might affect the Doppler signal itself. You may have some disturbance in the Doppler signal. In order to get a very nice Doppler signal, to increase it, you can just easily freeze the 2D image over there, and then you get a much more clear signal for the Doppler.
In this demonstration, Marion showed us how we can acquire a continuous wave Doppler spectrum in a patient, or actually an individual, with physiologic tricuspid regurgitation. Something which is often very difficult to do, especially if the signal is very weak. But there are many, many other ways we can use continuous wave Doppler as well. Even though we can measure high velocities, we don't exactly know where these high velocities occurred. We only know that they must have happened somewhere along the line of the continuous wave Doppler. Well, as I explained to you previously, there is a limit to the maximum velocity that we can record with the help of pulse-wave Doppler. And this maximum velocity is defined by the so-called Nyquist limit. In other words, the limit of the pulse repetition frequency with which we can still record unambiguously the maximum velocity. And the Nyquist limit is equal to 1/2 of the pulse repetition frequency. Now, it's quite difficult to understand, but you can get a better appreciation if you look at this movie reel. Now, this movie reel is obviously moving clockwise, but if you look at this part of the movie reel, you will have the impression it's actually moving backwards, which it isn't. The reason is that the sample rate of the movie that we're looking at, in other words, the PRF, is less than half of the actual speed of the reel, and thereby we have the impression that the reel is moving backwards. So let me try to explain aliasing with the help of this graphic here. Imagine we have a clock, and the hand of the clock is traveling obviously clockwise in this direction. And if we sample, in other words, if we look at this clock 4 times per cycle, in other words, every 15 minutes, it will be quite easy to determine that the hands of the clock are really moving in this direction, clockwise. However, if we only sample every 40 minutes, in other words, 1.5 times per cycle, then we will have the impression that the clock is actually moving counterclockwise. This is exactly what happens with Doppler and with aliasing. And this is what happens in the spectral Doppler tracing if we exceed the Nyquist limit. Remember, normally we have velocities which are displayed above the zero line as velocities which are moving towards the transducer, while velocities below the zero line denote flow away from the transducer. If we exceed the Nyquist limit, then this part of the curve, the high velocity part, is simply cut and then displayed down here. This is the typical pattern you would see if aliasing is present. In contrast, if we use continuous wave Doppler, we do not get aliasing. And here again, the table to summarize the difference between pulsed wave and continuous wave Doppler. A Doppler signal is also generated from tissue, and this signal has a lower velocity and a higher amplitude. And with special filtering techniques, one can focus only on the tissue component of Doppler, and this allows us to perform what we call tissue Doppler imaging. There are many ways that we can use tissue Doppler, and tissue Doppler can provide a lot of insights into the physiology and pathology of the heart. Here's an example of a tissue Doppler spectrum where the mitral annular velocity is measured. You can see the spectrum looks very similar actually to a normal pulsed wave Doppler spectrum. The only difference is that the velocities are much lower. You will hear more on tissue Doppler in the chapter on color Doppler and in a chapter where we deal with other technologies and newer technologies of echocardiography. You've almost made it through this chapter on physics and principles of ultrasound. But I'm afraid we're not quite done yet. We talked about spectral Doppler, but we still have one more chapter to go. Now we need to talk about color Doppler.